Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and as a spine surgeon, always very intrigued in learning from this.
You're going first.
In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3,
2, 1.
Good morning, everyone. Welcome to our bi-weekly Seattle Science Foundation STAT Talk series. Our speaker today is going to be Rick Chua, who is one of our colleagues down in Arizona. Everybody knows Dr. Chua pretty well. We're going to present some interesting cases, and then we're going to have Dr. Chua give a nice talk on arthroplasty. And I thought we would start off. Good morning, Rick. How are you doing?
Good morning, Rod. Thanks for having me. I'm doing great. How are you? You're looking great.
Doing good. Thank you. I'm sad, I went to my daughter's first soccer scrimmage last night, so that's usually a sign that summer's over. So I'm kind of bummed, but at the same time, I'm a big soccer fan. So excited to, one of my daughters is a senior and then the other one's a freshman. So we're going to go ahead and start. Dr. Mohsen Karimi is going to present some cases. In fact, a couple interesting ones. So would love your perspective.
Yeah, great. And also great to meet all the new fellows. Good morning, Jens.
Rich. No curveballs. This is Jens. Thanks for doing this.
You're welcome. Good to see you, Jens.
I love the focus today, disc arthroplasty. You and I sometimes disagree about minimally invasive surgery and what that is. For me, the minimally invasive surgery breakthrough has been motion preservation and intelligent decompressions. And I think you and I have agreed on that on many occasions. None of the cases today are curveballs. They're all straightforward, but they allow for fundamental discussions. So Rick, good morning. And Mohsen is getting Corey to help.
So Rick, one of the things, Jens, I think, we both probably feel the same way, is that, and actually I blame Jens for this, but, for some reason, I think the industry in general, I sort of forgot about arthroplasty until I came back to Seattle. And Jens kind of rejuvenated my spirit. So I'm glad we're talking about this today. It's an important topic.
Yeah, and I know while we're getting set up, I know that you guys host an enormously popular arthroplasty course, which I've attended before and not spoken at. But I think it's for the young audience out there, the young surgeons. I think it's a great reminder. It's nothing new, but I think it's a technique and a topic we have to kind of keep pounding at people. Because we sort of get relegated to our old-fashioned way of doing anterocervical fusions. I know, and before we start, I know if I had a single or two-level cervical disc problem, radiculopathy or myelopathy, I would want an arthroplasty done on me if it was the appropriate indication over fusion. So happy to talk about it.
All right, Mohsen, without much further ado.
Yep, good morning. So I'm going to present the 3 interesting cases about ADR. So first one, we did the surgery yesterday, 65-year-old male. That was very interesting history. Overnight, the loss of grievous rings and weakness of the left arm and hand in June 2025. And then pain of the left shoulder and back of his arm and very severe atrophy of the left hand. Social-wise, alcohol, ex-smoker, diverse, and very active, like skiing, hiking, and dirt biking. So you see the physical examination. There was hand intrinsics, very weak, and grip on the left side, very weak. There was no, upper motor neuron signs on the left side or right or lower extremities. So see here, C7T1 disc herniation, mostly on the left side, and mild core deformation. And this is the CT scan. You see as well, bilateral foraminal narrowing and the spinal column stenosis. So summary, 65-year-old, left hand, severe grip, weakness, atrophy, and pain.
What's interesting, Rick, actually, when I saw this guy, his MRI report was read as normal. And then I was trying to get an EMG, and the insurance company wouldn't approve the EMG. And then finally, we ended up getting the EMG. I just wanted to rule out, it was kind of a weird history. And he had a little bit more, C8, but he did have a little bit of triceps weakness, but it was mostly grip. So.
Go ahead, Rick. So common problem, aging spine, spondylotic patient, insurance companies practicing medicine without a license or privileging in the respective hospitals, but that's a side note. Multi-level spondylotic spine, and then the age-old C8 query. Is it C8? Is it T1? What root is it? Question mark. So thoughts, decompression only, decompression fusion, multi-level arthroplasty, etc.
Yeah, so great case, right? This is a person we probably see every week in clinic. The story sounds like a C8 radiculopathy predominantly, but agree can always be one level above or one level below. But the hand intrinsic weakness for me kind of sells it as a C8 radicular pattern. Certainly on the imaging, it looks like there's a lot of degenerative spondylotic changes at C6, 7, which I think is where you see the big anterior osteophyte, posterior osteophyte, pretty bad foraminal narrowing on both sides. No upper motor neuron findings, which is important. When I go back to the MRI scan, I think that looks like a soft disc herniation at C7T1 out in the foramen. And, I think the issue is sort of what's the appropriate surgical approach. And because this is a surgical lecture, we've assumed the patient's either failed conservative therapies or has a rapidly progressive neurological exam, which it sounds like he does. Even though today's talk is about arthroplasty, actually, this for me would be a really great indication for an MIS, posterior cervical foraminotomy discectomy at C7T1. However, an anterior cervical arthroplasty would be very, very appropriate with a couple of caveats. Disc arthroplasty, as we know, is motion preserving. It reduces postoperative pain compared to fusion. It reduces adjacent segment disease significantly, and we have that data now over more than 10 years. The challenge is C7T1, which I think is the level of this disc herniation. That's actually a level that I think is not approved by the FDA. So going back to insurance companies, a really smart medical director for an insurance company might not allow a TDR at C7T1. In any event, I think it's a very appropriate candidate for a TDR at C7T1. Some people have said that we should be cautious about preserving motion at a motion segment. And I've even been in legal cases where some experts have said you should never do a disc replacement at a junctional segment. However, I don't think there's any biomechanical studies to support that. And then for this young surgeons and fellows, this guy looks like he has a pretty thin neck, and C7T1 shouldn't be an issue with the approach. But if you're planning an anterior approach of any kind, you may want to get plain X-rays, lateral view, or look at the CT scan and draw a line from the clavicle paralleling the disc space to make sure that the surgical approach is achievable. But I think this could be either an MIS posterior cervical disc, TDR at C7T1, anterior cervical fusion at T1, which I would avoid doing because of how profound the degenerative disc disease at C6-7. I would not probably do a 2-level surgery. I would just focus in on the C7-T1 and treat that level.
And Dr. Chua, and this goes back to then Dr. Skuin, whose case it is. You mentioned soft disc versus hard disc. Do you mind going back to the CT scan, Mohsen? So soft versus hard disc. So tell us how the presence of a hard versus a soft disc influences your decision to do a posterior decompression femonotomy versus a anterior procedure.
Yeah, great question. So in general, a posterior operation is much better at taking out a soft disc because you can directly kind of tease out that fragment. If it's a hard disc, you're really just indirectly decompressing the foramen by removing the posterior elements, and that anterior osteophyte is still there. Now, occasionally you can slide a little impactor down there and just kind of tap it gently and flatten it out. But if it's a hard disc or an osteophyte or a calcified disc in the foramen, then an anterior approach is probably more effective at directly decompressing the foramen and the nerve root. So I think on the parasagittal images, it looks like the parasagittal images are C6-7, and the left paraspinal image looks like there may be a calcified disc or a bone spur in the foramen. I don't know if that's the symptomatic side or the non-symptomatic side, but the C7-T1 foramen, in my opinion, looks symmetric and open on the CT. And then going back to the MRI, I think this is a soft disc in the C7-T1 foramen. And I think you can barely see that on the left image of the MRI at that penultimate disc. That looks like a soft disc starting to pooch out of the disc space.
So back to the surgeon, Dr. O.
Yeah.
So we have an ugly foramen at 4-5. We have a spondylotic segment at 6-7, and we have a disc fragment. I don't see a CT for the parasagittal area of 7-1, but why a consideration for an arthroplasty? Why not just a decompression at 7-1, and or why not treat the 6-7 segment?
I mean, honestly, I think you could go either way. The only trouble I have, Rick and Jens, is it does, I worry sometimes. You can see that on that sagittal view, there's a little osteophytic component anteriorly. And even though I think you can get most of this from the back, I was just worried, given the amount of weakness, just in terms of, I think for me, accessing this from the front, I think I can do a better job.
Mm-hmm.
Yeah. And 7-1, again, Dr. Chua mentioned it for our audience. You want to understand the manubrio-vertebral axis angle. So in some people, the C-spine is set low in the upper thoracic aperture, and in others, it's high, the ballerina necks. If you have a low neck, C7-T1 can have an oblique axis trajectory that makes a anterior decompression very arduous, and you have to actually sacrifice C7. But yeah, for me, this is, I would actually just venture, I would do, if I was convinced this is an isolated C8 radiculopathy, I am actually in agreement with Dr. Chua. I would do a femonotomy at 7-1, but certainly a conversation with the patient about including 6-7 as a very spondylotic segment would be part of my decision-making offers to the patient of deliberation. Mohsen, take it forward.
Yeah, so we done TDR yesterday, and then post-op recovery was very good. And then that was like the standard surgery. So the second case.
So hang on, so is that disc slanted backwards? You don't have other images. So it looks like its trajectory is aiming backwards and downwards a little bit. Is that the case or not?
I don't think so. This is kind of lots of.
No.
It's an artifact? Okay.
Yeah, it's artifact.
Yeah.
Okay. Because getting in coaxial is important in those, yeah.
Yeah, that was the best kind of,
That's not an
images,
image.
but they are not.
Yeah. It's coaxial
Very
to this
accurate.
space, yeah, okay.
And Mohsen and Rod, did you find a soft disc or mostly a hard spur way out left?
It was both actually, and Jens scrubbed in as well. And the nice thing about C7-T1, what I like about doing an ADR, you don't have to worry about the vert. So we went pretty far, and I feel like we traced the nerve all the way past the joint And immediately, I don't know, Jens, what you thought about the decompression.
That was a well-decompressed C8 root. It was kind of impressive to see. So that C8 root definitely was free and clear.
Yeah, nice job.
Okay, the second one was a patient, 49-year-old female. Chief complaint was sensory issue on the right hand for 4 days before, referring to us. It was like a shooting, stabbing pain in neck and mid-back, loss of functionality. She was so active. And then because of the loss of grip and weakness of that was, trouble in her function at work. So I'll look at the physical exam. So finger abductors and grip was about 4 out of 5. And then no triceps reflex, and then a little bit of hyperreflexia on the lower limbs, but negative Babinski often. And this is the X-ray flexion extension. And this is the MRI. You see C3, C4 with mild core impingement, herniation. And then this is C6, C7, the same, mostly, on the right side, you see the herniation, and correlate with C7 symptoms. And this is the CT scan, C3, C4, C6, C7, and this is parasagittals. So again, 49-year-old, right hand severe pain and weakness.
Beautiful.
And so I just want to review, the history is 4 days of hand numbness and hand weakness, no arm symptoms of any kind, and no upper motor neuron
Let me
findings.
just specify, this is my patient. So this is a physician and it's actually an anesthesiologist who can't grab this anymore. This is more than 4 days. I forgot the exact timeline, but that short term would not lead to surgery. But
Okay.
I think it's more 4 weeks or so, but I can't give you a specific number. But this is a physician colleague who can't grip right and has had some discoordination symptoms, but no frank myelopathy to my exam. But clear could not exercise the hand strength on the right side to kind of grab the intubation gear and hold it and exert tension. So triceps, pectoralis weakness, but the main problem was also a lack of grip strength with some dullness, and very concerned after a fall skiing head first. So had electrical sensations at that time. Very healthy individual, practicing physician. And here we have a 2-level problem with a clear-cut lower cervical spine problem, but a cord impingement plus minus cord signal changes. So here you go, Rick.
Yeah, so great case. So I think for me, I try to decide, is the patient symptomatic from the C6-7 level or the C3-4 level? Sure, we can have a fall and had some transient, Lermite's phenomenon, but if his current neurological symptoms and exam sounds like it's more likely the C6-7 level than the C3-4. So I would focus the treatment on C6-7. Having said that, also, I think the C3-4 level, the axial image, I'm not terribly impressed with that very, very small central disc herniation, and I think that could be followed clinically. Doesn't sound like it looked like that there was any upper motor neuron findings at all on the current exam, even though he had that skiing issue and that incident of a transient Lermite. So I would focus on C6-7. Again, a little bit unusual that this is C6-7 disc herniation on the right. Should give you a C7 radiculopathy. There really isn't much arm symptoms. I thought there was no triceps weakness. It was predominantly hand. So like Rod's concern on the first patient, I would probably do an EMG for this guy just to make sure it's not carpal tunnel, cubital tunnel. But if that was all negative, I would only focus and treat C6-7. The images are delightful and clearly shows a soft disc herniation, that axial on the right at C6-7. You can see the intensity of the disc fragment is very, very hyper intense, and that's equivalent to the disc material. Again, this for me is a pretty straightforward MIS tubular foramino laminotomy and discectomy. And then I would follow the patient at C3-4. Again, wouldn't argue motion preservation, C6-7 disc arthroplasty would certainly be appropriate as well. But I would not treat the C3-4 level.
That's a very insightful statement. We have this international group of sports and spine surgeons, and we meet in a variety of settings around the world. And we should include you in that in the future, Dr. Chua, if you have time to add to your busy schedule. But all of us struggle with these incidentally found C3-4 disc herniations in high-performance athletes. It's not a high-performance athlete, but a high-performing colleague. So, and there's some signs of C7. Yeah, thanks for the round circles there demarcating that this is a mixed root syndrome, whether it's 7 only or 7-8 is hard to tell. This is clearly a fresh disc herniation. Let's put our new partner, Dr. Mark Kramer, on the spot. He's a neurosurgical colleague. Can you get the microphone? Discectomy, foraminotomy with your University of Wisconsin and now Seattle Science Swedish Neuroscience Institute, I misspoke, experience decompression only or more and ignore C3-4? If this is a Badger football player?
I like the idea of the posterior approach, especially if that there's some other cervical disease. And, it's hard to predict the future. With the soft disc herniation, I think it's a very reasonable approach from the back, and throw a tube down and decompress it posteriorly.
So this is a physician colleague, and this was a physician colleague who got multiple opinions. And once that C3-4 was known to that colleague, that was also a big decision-making factor. We had iterative discussions on, I think, several visits over 2 or 3 weeks, and we proceeded with, drum roll.
Yeah. So yeah, we did the ADR, C3, C4, C6, C7, and this is post about 14 months. The patient was so happy, no more weakness, normal function. And yeah, so flexion extension, you see the movement of the disc. Yeah.
So very arguable point, because I actually, looking at this in retrospect, again, although I clearly always like to consider foraminotomies, and we discussed this, a more global solution was of interest to the patient, and that weighed the day. The patient actually had a complication in terms of a Horner syndrome. I've not had a Horner syndrome in several years, and we did have a Horner syndrome that's lasted for about half a year, but she's, I think, 2 years out now, something like that, and pretty much returned to normal life pretty rapidly from a neurologic perspective after. It's certainly an arguable point, and again, there's a lot of controversy what to do with these central disc herniations at C3-4, wait and see or take it out. Rod, any thoughts on that from your end?
Yeah, I mean, they're tough, and for some reason, I don't know why, I always happen to see them in tandem, whether it's just a little bit. I just saw another one. I honestly, I think this is a very reasonable approach.
So Dr. Chua, from your end, biomechanics of disc arthroplasties are now getting a greater attention, and this is an implant system. We don't have to mention the name, although this is a non-CME event that is unconstrained, and if I look very critically at 6-7, there's a little bit of translation going on. This is an unconstrained, or famously unconstrained disc replacement. Thoughts on biomechanics and making the biomechanics of the disc suitable to the specific patient and the level maybe?
Yeah, great question, and something I won't go over in the talk, so I'll talk about it briefly here. I think a lot has been said about the biomechanics of cervical disc arthroplasty, and I'm just a simple man, so I try to keep it simple. Before we had disc arthroplasty, it was either fuse an unstable segment or a stenotic segment because we think there's micro instability, or don't fuse them because we want to preserve their motion. We didn't think about any other biomechanics than that. And now we've gotten crazy into the biomechanics of these different implants. Honestly, I think an argument can be made that everyone should have a constrained device. There's arguments that you could say everyone should have a semi-constrained or lack of constrained device. For me and my volumes, I really tend to try to pick something in the middle, so the bell-shaped curve, and something in the middle that I can use for everyone, because I'm just not smart enough to figure out every single patient's biomechanics for that level. So I try to do a sort of a reasonable middle of the road, which is typically a semi-constrained device. For me also, I think the more parts these devices come in, the more chances for failures and problems. So I like to go with as simple a device as possible, a 2-piece device rather than a 3, 4, 5-piece device that you have to put together and inject and do all those things. And then the last thing I would say, especially for the young surgeons with arthroplasty, is when you start doing these, make sure you follow your patients up at a year or 2 years. I don't think we really do a good job of our follow-up for anterior cervical fusions at a year or two. When I started doing disc arthroplasty, I started following now all of my patients at 1 and 2 years to prove that you're actually maintaining the motion, right? We can sell this as a great operation because it maintains motion, but if it doesn't maintain motion at a year or two, then we sold the patient a bag of goods. So I think it's important to follow these patients just like you've done here. The other comment I'd made about this patient is, it really is a patient-informed decision. So high-level athlete, someone who skis a lot, where, if you crash, you're toast. I think it's very reasonable to treat that C3-4 level. In my area of the country, a lot of bicyclists, pickleball, golf, low impact, low velocity type of sports. I would follow that level. And I have lots of patients with way worse stenosis and even cord signal changes that I follow with minimal, if any, upper motor neuron findings. And I followed them I've now been in Tucson for 20 years, and most of them have never ended up in an operation.
Really good point. Final case for Dr. Yeah, sorry, yeah.
From an insurance standpoint, how in the hell did you get?
Can't hear you, Rod.
Oh, I was just saying, from an insurance perspective, how did you get approval for this, Jens? Because I know I wouldn't have gotten approval.
That was actually not contested.
Really?
2 levels for this particular implant system is not contested, and again, non-contiguous, this was not even a question there. So insurance companies now actually prefer 2-level disc arthroplasties over fusions, and the outcomes data clearly shows an incremental benefit in 2 levels, not specifically non-contiguous, however, over fusions. So that's actually something, but non-contiguous disc arthroplasty is still something kind of newer. Final case for Dr. Karami, so fire away.
Yeah, so the last one is also a very interesting case, 66-year-old male, symptom of neck pain, radiating pain to both upper extremities, numbness in both hands. Symptoms started after an accident at work last year. And then he had ADR done C5, C6 18 years ago. So on physical examination, there was no motor deficit, and then no upper motor neuron or lower motor neuron signs. And he was active, walking about 20,000 steps per day.
Yep, sorry, you go ahead.
Yeah, so you see the X-ray from the disc replacement done 18 years ago. You see the motion at that segment.
So this was a case of mine that I did 18 years ago. This is just a quick FYI to look at longevity. We could not get the original films of mine. So I did this 18 years ago as part of the FDA study. I think this is one of the very first in the Pacific Northwest, outside the Bryant discs, which we did before that. And that's no longer available. So this is 18 years later, and a lot of questions have been raised about adjacent segment disease and all that. This is an isolated 5-6 disc. And what do you think here? So this is his long-term imaging 18 years later. What's the longevity of these discs like, Dr. Chua?
Yeah, great question. I think, in the US, the FDA trials, including your device, I think the 10-year data was around 2021, 2022. So we probably are at, almost 15 years of follow-up. The European data is much more than that. It's about 20 years out now. And the data is really quite good, at least at 10 years. The rate of adjacent level disease is substantially lower than 1-level ACDF. I think it's a greater than 50% reduction, even at 10 years. At 10 years, the device, adverse event rate is virtually 0. So it really has stood the test of time. And Jens, I know you're a little bit of a historian in spine surgery, but I'm proud to say that I'm practiced in the era where cervical disc arthroplasty came to be. And I hope that, ultimately one day, probably we should be doing, 2/3 of these operations we do are arthroplasty and 1/3 fusions or less.
As will be shown, I could not agree more. Boring for the audience, we don't disagree, but this patient has had an extremely active physical lifestyle, and he only came to us because he had a significant head trauma at work where a big metal drum banged his head, knocked him out, and he had some neck pain afterwards, and we found some spondylosis at the levels above and below. I think I got a CT myelogram. Do you have that also? Yeah. The CT myelogram. We want to make absolutely sure, if you don't mind rolling through that. But Rod, Mark, and certainly Dr. Chua, please weigh in. I was actually very happy to see this disc still moves. It's not a huge amount of motion. This was a 6 mm height implant, but the spondylosis above and below is totally within age and activity expectations, and there's no osteolysis, and the neural decompression at the index level looks perfect. There's no secondary bone remodeling. And there's a little bit of spondylosis left side at 6-7, but again, nothing that I could refer to the symptoms. Rod?
Yeah, I mean, I think on this, go through the sagittal, it looks good. I would say, having seen a bunch of your cases, this is a smaller disc than normal that you usually put a larger implant.
I'm an outlier there. I usually go for 7 mm, but this was the very first patient with this particular device.
Wow.
This was done 18 years ago as part of the FDA trial. I think this is the very first disc of this type in the Pacific Northwest. I put in some Bryant discs before that.
What's interesting is looking at the other levels, but also seeing what happens to the end plate at that level. And there's not much bone formation.
Yeah. And we're very keen on bone waxing. This is, again, there's a lot of fear and worry about this case at the time. I remember that because we had a randomization protocol that was highly secretive and complex, and there was bone wax, ossification agents, so anti-HO agents. Dr. Chua, do you use some form of NSAIDs or anything like that?
Yeah, I do. I try to follow the FDA protocol for all these devices, which is, I think it's usually 2 weeks of an NSAID. I think that makes a lot of sense. I also want to point out, this is obviously speculative and retrospective, but that C4-5 level, sure, there's a little bit of spondylosis, but I would argue that is substantially less spondylosis than you would see, let's say, if you did an anterior cervical fusion at C5-6. 20 years later, that level would probably look really gnarly. And it doesn't look bad. It's a little bit reversal of the lordosis, a little mild degenerative disc, but I think it looks great. And again, a testament to the FDA process, testament to industry putting the time and the effort to design these, and more importantly, a testament to skillful master surgeons to do these surgeries so that we can learn from your results.
No, thank you. But yeah, it was a lot of angst at the time. Dr. Karami, thank you very much. We'll pivot over to Dr. El Hashemi, and he is a neurosurgical colleague, and he put together 2 cases, and we'll try to make up some time. Those are very instructive discussion points by yourself.
I think Amir has a question in the chat too. I'm just going to get to it.
Sorry,
Is
I
there
didn't call that.
upper limit?
Yeah,
Upper limit for age and arthroplasty candidates. I actually don't have one. The initial FDA trials, I think, were limited to 65. But as you know, with FDA trials, that's what they have to do is narrow the bunch. So I think I've put them in up until 72, 73, as long as their bone quality is reasonable. And the cervical spine, it usually is. So I don't personally have an upper limit age for arthroplasty. It's really more the level of spondylosis and motion preservation of the level that's being treated.
So excellent point.
Thank you.
Amir, yeah, is that the answer?
I think it's a great point. There can be some young patients with some very advanced degenerative changes. I do look at the facet arthropathy, but I recently had a patient who was in his mid-70s, but is a former gymnast and was very interested in disc arthroplasty, and he was pretty arthritic, but I have been kind of expanding, who I consider a candidate, and I've seen some older patients do quite well.
Yeah, Amir, I would, we were sort of taught if there's too much degenerative disc disease, shouldn't do it. How do we determine that? Don't know. Disc space narrowing, modic end plate changes. The current thought is sort of facet arthropathy, degree of facet arthritis. If there's too much, shouldn't do a motion preservation surgery. Problem is, how much is too much? I don't think anybody knows. So what I've gone to is I do flexion and extension x-rays on all these folks. And if I still see the disc space height change with flexion extension, even if the facet joint is pretty arthritic, I'll still use them as a candidate for disc arthroplasty.
Great
Those are
point.
great points. Yeah.
All right, Dr. El Hoshemi.
Good morning again. So this is a case also for Dr. Chapman, 67-year-old male, multiple comorbidities. His past medical history is only significant, surgical history is only significant for an anterior C5, C6 foraminotomy done outside, where they did an uncinectomy on the left side. I will show it later on. So the patient presented to clinic with tingling in the right hand, muscle spasm in the neck, and some activity-based neck pain. The patient tried activity modifications that were helpful. Medications also were questionable. He did not try any other methods of conservative management. This is his exam, grossly intact except for some finger abduction and grip weakness, 5-. No pathological reflexes. His reflexes were normal. This is the previous image the patient had. As we see on this left side, we see this post-surgical changes with the uncinectomy done on this side, not very obvious with the degeneration and the age-related changes. This was done 10 years prior to his new presentation. So he we ordered a CT myelogram on this patient, and this is what was showing. This is the old post-surgical area, and this is the new images. We have severe foraminal narrowing on the right side. This is at the 5-6 level. This is the MRI, as you note here, significant foraminal stenosis. This is the level below. Also, we have bilateral here foraminal stenosis, notable on both the MRI and the CT myelogram. So an EMG was done for this patient. It was significant for C7 radiculopathy, mostly. Other than that, it was clearly normal. Any thoughts on this
There's
case?
one other thing. Do you have the flexion extension films? This patient actually had, this is a physician, and this patient had this anterior uncinectomy done, so we don't have parasagittal films. So this patient had a spontaneous fusion, C2 through, I believe, C4 or 5. I forgot the levels now. So the significant wasting is at the 2 levels below. And this uncinectomy was done in LA by a well-known colleague whose name we're not going to spell out. So general thoughts, Dr. Chua, on anterior uncinectomies as a form of effective foraminotomy for cervical patients. Anachronism, historical kind of aberration, or still relevant?
Yeah, could you go back to the history real quick, Mohammed? I kind of missed that. So anterior cervical foraminotomy, C5-6, many
10
years ago. Yeah.
Never really got totally better.
Yeah. And then the current presentation is radiculopathy or myelopathy?
Radiculopathy.
Radiculopathy at that level?
C7 on EMG, no, the level below. So
C6,
this
7.
level always never got better. And then the
Yeah.
patient has an active radiculopathy at C6, 7, so C7.
Yeah. So, this anterior approach, uncinate process resection, anterior cervical foraminotomy, I think historically was popularized by some of the Asian surgeons. Honestly, I did a few in my training and a few in practice. I didn't do a good job of it. I think at the end of the day, the exposure is the same as an ACDF or arthroplasty. You're just maybe increasing your risk of exposure to the vertebral artery, Horner syndrome, getting out too far laterally, and most importantly, an inadequate decompression. Not having seen the original films from 20 years ago or 10 years ago, hard to argue or criticize, But I think what we've seen now is development of severe degenerative spondylosis, disc space narrowing, which can also cause stenosis of the foramen and the craniocaudal dimension, but you've also got reversal of the cervical lordosis and some early kyphosis. So wasn't a big fan of the anterior cervical foraminotomy, but I think it's one of those procedures that you've got to do a lot of them to get really good at.
So pointed question then, is this a case, assume that the levels above 5, 6, 6, 7 are spontaneously ankylosed. The patient does not have an inflammatory diathesis or a known ankylosing disorder, but they're fused, so we decided don't have the images for that. Is this a candidate for a disc arthroplasty when you've had an anterior uncinectomy, or is that too destabilizing?
Yeah, great question. I do not think it's a contraindication. I think it's maybe a marginal indication, but I don't think it's a contraindication. I think the challenge is in general, should we put a disc space replacement inside a fused segment, I think is what you're asking. So if this level is actually...
Oh, sorry, it's a level below the spontaneous fused segment. So
Oh, gotcha. Okay.
Working
So if it's below the spontaneous fused segment, I think it's okay to consider a disc arthroplasty. That's actually kind of a hybrid approach, and there's a lot of surgeons that have experience in Asia and now increasing experience in the US where we do a hybrid, or you end up in a hybrid procedure, which is a fused segment adjacent to a motion preserving segment. My concern, though, is that the alignment of that symptomatic level C6-7 might increase the risk of failure of a disc arthroplasty, 2, 3, 4, 5, 6, 6, 7. But, I think it's reasonable to do a C6-7 disc arthroplasty. I think there's probably a little bit higher risk of failure for that device.
All right, move forward.
So
Mohammed.
this is what was done. This is intra-op, C5-6, C6-7, arthroplasty was done. Patient post-op, this is the post-op image. He was seen twice since the procedure. The device is actively functioning, inflection and extension, as you note here, and he's very happy.
Beautiful.
Yeah, so we used a more restrained device that does not move as excessively as others. It's a different, you'll talk about that probably in your discussion later, Dr. Chua. It's an interesting composite material. It's pre-assembled. It's pretty nice to put in. And I chose this more mechanically rigid device due to the juxtaposition next to a spontaneously fused segment, which you can appreciate more on these images.
Yeah.
We did carefully oversize the patient with skeletal traction pins to reestablish some lordosis, and I think we at least neutralized the neck alignment. It's not perfectly realigned, but he was slightly kyphotic, as you astutely observed beforehand. So, question to you, Dr. Chua. Restoration of anterior column deficits with disc arthroplasties, can you correct, at least within reason, a kyphosis using disc arthroplasty?
Yeah, great question. I think you can. I think you just have to do a little bit more carpentry. You've got to get really good, wide, bilateral uncinate process resection, and maybe even a little anterior uncinate resection. We think about the uncinate process down at the foramen level to decompress the nerve root, but remember the uncinate process also comes anteriorly. So a wide decompression, I think, is the best way to restore some of the alignment and lordosis of the cervical spine. Prior to arthroplasty, we would just jam in a giant graft and get the indirect decompression. But I think for the young surgeons, you have to know that the technique and the carpentry of doing disc arthroplasty, if you're going to restore height and alignment besides just motion, it's a little bit more work than an ACDF.
Perfect, yeah, so he did very well. Watch out, he's on the pickleball army, so he's had a full resolution of symptoms and is very happy with that. But we obviously had extensive discussions about what to do. Merging to the next patient.
I have just a question.
Yes,
I was
fire
not
away.
on this case. The level above is also severely degenerated. So what's your consideration when deciding on this 2 level?
He's fused. If you look at the parasagittal CT scans, he's actually fused there.
Oh, totally fused.
Totally fused. The facet joints are totally fused. So 5, 6, 6, 7 are the motion segments. If you look later, we can look through the CTs. It's spontaneously fused. Okay. So that's always important for me to look at the facet joints also. Question to you, Dr. Chua, as you're getting ready for the next case. Facet joint integrity, facet joint arthropathy, indication, contraindication for cervical disc arthroplasty.
Yeah, again, early on, I used facet arthropathy as an indicator of maybe not preserving or restoring motion, but I had a hard time really quantifying, how bad is the facet arthropathy. So I sort of replaced that with motion on flexion and extension X-ray. So, we look for motion, meaning spondylolisthesis and translation, but in the cervical spine, what I look for is in flexion, the anterior disc space closes and the posterior disc space opens, and in extension, the anterior disc space opens and the posterior disc space closes, irregardless of what happens at the facet joint, right? Because the joint is a three-dimensional anterior to posterior segment.
Great point. So remind me to look at the CT later with you. You'll see that the facet joints are all fused. Next case, and then we have one final presenter.
Yeah. So this is the second case. This is a 41-year-old male, history of migraine, mandibular fracture. He presented to clinic with low back pain, numbness, and tingling in bilateral heels and ankles. He tried most of the activity modifications, epidural injection that were helpful, some physical therapy that was also helpful for his symptoms. On his exam, he was grossly normal, nothing showing up, and this is his MRI. On MRI, as you know, the spine, except for the 4551, looks grossly normal. This is at the L5S1. The disc is totally degenerated. We see this diffuse disc bulging, and this is a different cut. We have this right foraminal stenosis with a fragment. Also, the 4-5 is a bit degenerated with the loss of the T2 signal. The patient's symptoms were mostly more of a discogenic mechanical back pain rather than the radicular pain. When you see this image, you expect radicular symptoms. This is his X-ray preoperatively. Again, noted the degeneration at the 5-1 and the severe foraminal stenosis. CT scan also with the myelography was done and showed the central canal is fine. We see the degeneration and the foraminal narrowing again.
You gave it away.
Yeah.
Give it away. So, psychosocially completely normal, productive individual, no opiate problems, some partly calcific central-lateral disc herniation at 5-1, but mainly low back pain, axial symptoms, some facet arthropathy. I usually get a SPECT scan. I don't remember what that showed.
It showed activity. I wasn't able to pull out the right images, but it was active.
Some activity
at the right time.
And again, the question of facet joints comes in. So we've talked a lot about lumbar alignment, and again, we all have to acknowledge, I usually do it, you're an esteemed board examiner, Dr. Chua, we don't have a cure for back pain, as I always say. I know you serve as an oral board examiner for the AANS. So the subject of lumbar disc replacement, please talk to us about your thoughts on management of back pain, axial back pain mainly, with maybe some radicular symptoms through fusion and or disc arthroplasty in a relatively young, physically very active, healthy-minded individual.
Yeah, great case. So, in my training as the dinosaur, as you and have previously implied, this would be no operation, back pain only, degenerative disc. Even if we thought that was where the pain is coming from, no operation. I certainly learned early in my career that some of those patients can do well with an operation if properly selected. First is isolating the pain coming from the disc space or the motion segment, whether it's SPECT scan, discography, facet blocks at 5-1 versus L4-5. I think those are all important diagnostic tools. If you can decipher that the pain is only at 5-1, then I think there's a reasonable option for surgery. It's either a fusion or a disc replacement. Unfortunately, when lumbar disc arthroplasty came about, there was a lot of backlash and pushback from the insurance plans. And so I really early in my career did very few. And the initial implants were challenging to put in. We weren't that sophisticated with our vascular surgeons yet on anterior retroperitoneal approaches. And so I have very little experience with disc arthroplasty. However, the literature is quite clear for something like this. Disc arthroplasty is extremely effective, low complication rate, and most importantly, reduces the adjacent level disease. And we know this guy already has a degenerative disc at 4-5. So I think a disc arthroplasty makes total sense. Because I don't have much experience with that, I would inform the patient of that, but I'd also offer them an anterior lumbar fusion.
Well said. Dr. El-Hashemi, show us what we did. You kind of gave it away already, but
So what was done was a left-sided retroperitoneal approach for a 5S1 disc replacement using this large implant. Patient did fine post-op. This is directly post-op, and this is on also on follow-up. The device was still functional. Patient is very happy with the procedure on his 6 months follow-up, and all went fine.
Jens, there seems to be a recent resurgence in anterior lumbar arthroplasty, it seems, in literature and in the community. It's not very popular here in Tucson or in Phoenix, actually. Has the insurance company, has that milieu changed for this?
yes. So you mentioned the evidence before, Rick, and it's actually very favorable compared to fusions. The rate of adjacent segment disease is much lower. The rate of back pain decrease is actually way better than in the initial FDA studies. And very consistently, the return to normal activities is way faster than with fusions. So that's the long-term data. Interestingly, yet again, just like in cervical disc arthroplasty, two-level lumbar disc arthroplasties are way better in terms of adjacent segment prevention than fusions. One other note that the TBI colleagues, and again, I'll make self-advertisement for our motion-preserving course, October 23rd, I think, don't quote me on the date, but late October, is dramatic, and that is that basically the survival rate of disc arthroplasty in the lumbar spine is better than that of the surgery of the century, which is total hip arthroplasty. So this is a very favorable approach. That's a clear thing. I self-critically have to say, if you go back to the AP, I did not do a perfect job centering this, and I'm not sure why. I'm like probably almost a centimeter, maybe 5 millimeters off.
Millimeters.
So not sure why, but I accepted this at the time. I usually am very meticulous about getting this perfectly centered. Any questions about longevity being adversely impacted by being off the midline like this, Dr. Chua?
No, I certainly haven't seen anything in the cervical spine, my experience or the literature. I think biomechanically it makes the most sense that you have it dead center perfect, but I think you're a little too critical. This might only be 2 millimeters off the midline. It's not even the width of the spinous process. I think they'll probably perform just well. The more important thing is how big the footprint is. And you can see on the lateral, that footprint is way back to the back. It's big side to side. So I think that sizing will probably overcome a millimeter or two being off the midline.
I love talking to you. Thank you, Dr. Chua. If you look at the alignment postoperative, what I have to say is in this ISSG era of, go forwards, please, the restoration of normal lumbar alignment through these disc arthroplasties is astounding to me. And it's effortless. The spine rebalances itself. So where it's previously hyperlordosed at other levels, just by jacking open after full anterior release, mind you, is actually very gratifying to see that it's a really normal alignment. This has not been looked at really by the ISSG or by the TBI colleagues. So that's for me is a significant benefit of these procedures. And this patient has been very happy so far. I actually have to say, as much as I'm a total fan of cervical disc arthroplasties, I actually like lumbar disc arthroplasties even better because they've held up very nicely. Right. But you have to select the patients ultra carefully. You have to establish a relationship with them well over a year, I would say, to make sure that there are no pitfalls. And I always say the same thing. I quote the initial FDA studies. This is not a cure for back pain. I can hopefully get 50% reduction of back pain. And if you're going for a total global solution, that's always nice. That's aspirational, but I can't promise that.
Agree.
So next, final sequence of cases, and we'll have to kind of rush through probably just one case. He prepared two. Just the second one, yes. So we'll stay, we'll show the other case at a later point in time. So Dr. Hagai prepared two cases. Also want to commend our fellows. They did these cases all yesterday on relatively short notice, and we had a very busy day in the OR. Dr. Hagai Amsterkhan has selected this particular case.
Okay, so my case is not as straightforward or arthroplasty like maybe the
Oh,
previous
no,
case.
yeah, go second case. Oh, sorry, the arthroplasty case.
The arthroplasty case, okay.
Sorry, yeah, good. Okay.
So this is a 70-year-old female. She presented to clinic suffering from neck pain, radiating to her right arm. She reported several falls, even though her exam at the clinic didn't show gross instability. There was no weakness on exam. There were positive Babinski on the right side. The left side was not examinable because she had foot surgery recently, and again, no gross instability. She had a posterior lumbar decompression. That's her x-rays. And on the cervical MRI, you can see stenosis on C4-5 and C5-6 mainly. So again, a 70-year-old patient, cervical disc degeneration, cord impingement on 2 levels at least, some myelopathic signs, pain radiating to the right arm. That's the question today.
So this patient is well-versed in multiple medical offices. That includes visits to New York, Miami, and in the European arena. And the plethora of opinions rendered for the treatment of this was simply amazing. Ostensibly, there is mild myelopathy. I don't know what I rated her exam, Nurek 2, Nurek 1?
Yeah.
Nurek 1 or 2, I forgot what I rated it as. I have an MJOA, and it's in the 13-plus era, but there was no obvious motor deficit.
Can you go back to both levels, the axials on the last slide?
So pretty ugly cord compression at 4, 5, 5, 6. The patient had a question of C7 things, and you can literally open up a differential discussion point of surgical procedures for this patient, anteriorly and posteriorly fusion and no fusions and levels. You can literally pull whatever you want out there. This patient had so many different opinions. She was with me initially, and then she came back to me. So thoughts on this? This is a mild myelopathy with cord compression. No real cord signal changes, although some people said there is. Radicular symptoms, mild myelopathy symptoms, again, mild long track signs, I mean to say. No convincing, clear-cut, isolated radiculopathy. I forgot what the EMG said. We did get an EMG also. There's a CT myelogram floating around also. Thoughts?
Yeah, no, this is actually pretty straightforward for me. I think she is symptomatic, number one. Both levels should be treated because the cord compression is significant at both levels, especially on the axial. So I have no problem justifying a 2-level procedure here. The options are 2-level anterior-cervical fusion, 2-level anterior-cervical arthroplasty, posterior cervical decompression without fusion, laminoplasty 2-level, and then the worst, in my opinion, is a 2 or 3-level posterior cervical decompression and instrumented fusion. But because the topic is arthroplasty, I think this is a great person for an arthroplasty, even without CT, even without flexion extension x-rays. For her age, she has relatively good disc space height. The discs are black, but they're not collapsed. I bet her facet arthroplasty is not terrible. I bet if you do flexion and extension, there is still some motion at both 4, 5, and 5, 6. So this would be a very straightforward 2-level TDR.
That was the flexion extension film. We can see some facet arthropathy at 6, 7. But again, to my repeat exams, there was no clear-cut radicular disease at 6, 7. There's some foraminal stenosis. You can see some facet arthropathy there, but I actually love being a simpleton.
1 level.
No, so go ahead. Show what we did.
Oh, yeah. Right.
2-level arthroplasty.
Yep.
And again, I was actually thrilled. I'm not sure why 5/6 tipped like that. The intraoperative films look totally level. I'm not sure whether we did an eccentric decompression there. Clinical outcome on your review?
She's about 3 years out of surgery. She's very happy. She went back golfing, traveling the world again.
And she had multiple reviews of the postoperative images by other colleagues in the Mediterranean area, and they all said, this looks great, and no concern about 6/7 at this point in time, neurologically or structurally. But yeah, 2-level arthroplasty, here's a more rigid device in case example. I chose that because this patient is actually extremely active, and despite her age, the insurance company had no problems paying for this.
Yeah, no, I think well done. I would likewise done a two-level arthroplasty and save C6/7.
Yeah, we concur, yet again, fantastic. With that, I thank our fellows for their late night work in putting everything together. And we'll switch to Dr. Chua's talk. Thank you, Dr. Chua, for being here. Dr. Richard Chua is a professor of neurosurgery and director of minimally invasive spine surgery and robotics at the Banner University of Medicine and the University of Arizona College of Medicine in Tucson, Arizona. He's nationally and internationally known. He directs the comprehensive spine surgery program. He is much practiced. He has a unique background in terms of working also in private practice, having the pragmatism of a successful private practice carry over into academics, a man of my heart. He has an active ongoing research program, robotically assisted and image-guided less invasive surgery techniques. What makes him particularly fascinating is he's the founder of the Nepal Spine Foundation, and he's actually on the faculty of the Tribhuvan University Teaching Hospital, TUTH, T-U-T-H, and I have the great privilege of seeing him in action there regularly. He travels there at least once a year. He's also performed surgery and innovative surgeries in the Maldives, Vietnam, and Thailand. So he's truly nationally, internationally known. We're very proud and privileged to have you here today and share your thoughts about cervical disc arthroplasty. And we also thank you for your very insightful discussions this morning. So Rick, great to have you here. I look forward to your presentation.
Thank you, Jens. It's always a pleasure to be a part of this program and all of your programs. Thank you, Jens and Rod and everyone there at SSF. Welcome the new fellows. You're on target for an amazing year. So this was a little bit of a last minute, so I'm here to talk for a non-CME sponsored talk on cervical disc arthroplasty using the Prestige LP. And we've talked a lot about indications and a little bit about the technique of surgery. And I don't want this to be a total talk about arthroplasty, including the technique. I really want to review kind of biomechanics and the literature, because I think as we move forward in offering these procedures to patients, we have to understand the literature and what it tells us. So I am a consultant for Medtronic. I have visiting surgeons come here to watch me do the Prestige LP surgery. I actually was on the design team that helped redesign some of the instrumentation from Generation 1 to Generation 2, and I helped write the technique guide for whatever that's worth, my liberal arts background. So I'm going to talk a little bit about the overview of the device, mostly about the clinical data and not much about the surgical technique. I think most of all of you know that the surgical technique for arthroplasty is pretty standardized, not very different depending on the different implants. And so as skilled, masterful early spine surgeons should know that technique quite well. So we'll talk about Prestige LP. It's been around for quite a while. As Jens had mentioned, a lot of other predecessors in the Medtronic family that started out with the Prestige ST, which was a steel device, and then the Bryan device came around and is now long gone. But this is the history of ST. And so the highlights really of the ST history are the predicate device was in 2002, which was all steel, not titanium. It was a ball and trough device with active fixation with screws into the anterior cervical spine. And for Jens, the plate or the screw hole design was designed around the Orion plate. So for those of us old enough to remember the early anterior cervical plates. Fast forward to 2014, the first FDA approval for the Prestige ST or LP device, which is the titanium device, not the steel device. And then a few years later, they received the 2-level indication for 2016. And then in 2017, we redesigned the instruments to make it very modular and very efficient. So Understanding the biomechanics of the cervical spine is important to understand why we would consider motion preservation. We understand that the neck has these ranges of motion: flexion and extension, lateral bending, and axial rotation. And that's from the famous paper and papers by Punjabi. So the Prestige device and some of the predicate devices for Medtronic and the ball and trough were designed to preserve the motion and kinematics, which included flexion and extension with a little bit of translation, lateral bending, and axial rotation. And you can see the video showing the understanding or the idea of why translation is important. So translation is not as evident in the lumbar spine with flexion and extension, but is certainly more evident and is part of the range of motion in the cervical spine. Fundamentally, these are the motion segments, and in biomechanics of cadavers, these are, intact and disrupted spine. These are the numbers that are actually present. So you can see at every segment or motion segment, there is a bit of flexion and extension and a little bit of translation. And again, we have to go all the way back to the early 2000s to Punjabi and Reitman's papers to understand the biomechanics of the spine. So again, this device, perhaps different than the other devices, wanted to make sure that they kept translation as part of the motion segment, not just flexion and extension. And it goes by the biomechanical principles of the center of rotation. The center of rotation changes at every segment, and you can see on the far right the equivalent of SPECT scans, which show where that center of rotation exists in each of the levels. So that it's not a fixed center of rotation for every level. It changes depending on the level of the spine. And so it's the anatomy that dictates the motion and the center of rotation. And again, important, this probably highlights it more than anything. A ball and socket that does not have any translation would look like that on the left, whereas a ball and trough design allows for some translation. And I may have misspoke earlier. The current device is a ball and trough design, which allows that translation. This device is two pieces. It's very simple. It's a titanium ceramic composite that's machined as two-piece construction. There's no mobile core or free-floating core. Historically, the Bryan device, you had to inject some saline into the inner core. There are some other devices that have a mobile core in the middle of two fixed devices. And again, I mentioned I'm a very simple man, and the simpler the device, I think, the better. The less moving pieces, the less chance for errors or misadventures. This is specifically made with a titanium alloy, titanium carbide. It has a spray coating as well on top of it to help with some of the ingrowth of the bone. You can see the ratios of the metal. There have been several basic science studies, including animal studies and human studies, to show that the titanium ceramic composite is very safe. So the rat model, they injected the rats and then they checked blood levels. And then in patients, they've checked metal ion levels to show that there's really no release of the metal ions, pardon me, from the device. And in fact, if you look on the far right, I don't have a pointer, but if you look on the far right, the amount of metal in the serum post-op is actually less than what you would see for an anterior cervical fusion. Again, nothing we really considered when we do cervical fusion surgery, but something that needed to prove to the FDA. Again, comparison of metal on metal, I think the orthopedic surgeons with arthroplasties of the total joints would understand that there can be and there has been issues with metal on metal devices. And there really have been no issues with the metallurgy with metal on metal for the cervical disc, probably because the biomechanics are different than a hip or a knee as far as the axial loading. And so that's probably one of the reasons why the cervical disc arthroplasties can get away without any significant metal leaching out of the device into the bloodstream compared to the ceramic, the polyethylene, or the ceramic type total hips. Titanium is certainly, or titanium composite is helpful for imaging. Jens had shown a couple of cases of cervical disc arthroplasty, the early devices, which were pure, I believe, stainless steel or pure titanium, and there was a lot of metal artifact. It sort of forced us to get CT myelograms when we saw those patients. The LP device and other company devices are now much more image friendly so that you can do a reasonably good job of evaluating the level of the device if the patient has to come back for further diagnostic imaging. And here's just a couple of examples of reasonably good MRI behind the device, which is most important. This has got a fixation biomechanically based on a press fit into the disc space. So there's no active fixation with screws into the vertebral body above or below. There's no active fixation with a keel in the middle, which I think Jens had showed some early results of great results of early procedures. So this is a press fit with a little tiny rail fixation. The rails, I think, are maybe a millimeter in height. So a combination of press fit, rail fixation, and the titanium coating, spray coating, which helps with ingrowth of the bone. The instrumentation, very simple, sort of coaxial, modular, very, very straightforward, predictable, and reliable. Certainly, as surgeons, we get very much into our motor functioning and muscle memory. And many of you can probably do an ACDF with your eyes closed as far as handing instruments back and forth. So we wanted to design the instruments to be simple, reproducible, flexible, and very, very efficient. So there's really three instruments. There's a trial to look at height and the footprint. Once you find the right trial and the footprint, then there is a device that goes over the top, which is a drill guide, which creates some pilot holes into the cortex. And then there's a rail punch that creates the rails for which the rail fixation will slide right into. So preparing the disc space for the implant, again, simple, efficient, straightforward. Here's a close-up view of the instruments. This is the trial. Again, looking at the height and the depth. And then here's a guide that goes over the top. It's a press fit. You punch those little pins through the cortex. That's not for fixation, but that's going to give a little bony opening for the rail punch, which is the third piece. You can see it on X-ray. You can see it under the microscope under loops when you're fully seated. And then the rail punch creates the little slot or the channel for the two rails above and two rails below. The concept of distracting the disc space in disc arthroplasty is important, especially for the young surgeons. You don't want to over distract the disc space when you're preparing the disc space, but you want to do a wide, direct foraminal decompression. The key is that we're not putting in a 7, 8, or 9 millimeter height implant like we do with an ACDF. So we're not going to get as much indirect decompression. And like Jens, many of my implants are 6 millimeter tall implants, sometimes 7 millimeters, almost never 8 millimeter implants. But there is a device to help you get the device in with some intervertebral spacers and spreaders. Here are the different sizes, very, very simple. The ultra small is the 5 millimeter. The more common sizes are the 6 and the 7. And then the width is just the footprint. And I decide on that based on the anterior posterior dimension, not the side to side dimension. These are some more measurements of the device. Again, simple, efficient, and flexible as far as the technique of putting it in. That's enough about the implant. Again, lots of implants out on the market. Some have come and gone. This one has been around for quite a while, and I think this is probably going to stay for quite a while. And the reason is the clinical data. So here are the dates for the clinical FDE trial. They're virtually identical to every other trial that's been with every other implant. Know that it's essentially a 1-to-1 randomization of ACDF with allograft plate and 4 screws. So somewhere around 250 to 280 investigational patients for the LP versus anterior cervical fusion. Same index criteria, exclusion criteria. The endpoints are out up to 1 year, 2 years, and then ultimately 10 years. And here's the overall success without the functional spinal segment, which is kind of not that important. But you can see out to 10 years that there is an overall success for the device in improving the patient's symptoms and radiology. For those young surgeons, the FDA required 4 different categories of criteria where you had to have success, and only if all 4 individual categories did you have success in arthroplasty compared to fusion could you have overall success. So this is like a conglomerate of those. And you can see the most important thing is that the maintenance of the improvement across 2 years all the way to 10 years. Over time, it's maintained its loss of failures, where cervical fusions, we do have some failures over time. So again, really durable device. Here's the overall success with the functional segment unit, again, maintaining the efficacy and superiority over the anterior cervical fusion. Like anterior cervical fusions, we do need to be concerned or worried about subsidence. So here's a very nice study looking at the subsidence of each of the individual components of the device over 10 years, and essentially very little, if any, subsidence, somewhere around 10% over 10 years. And subsidence of 10% over 10 years probably comes out to about less than 1 millimeter over the course of 10 years. I'm fairly certain that all of our anterior cervical fusion devices or levels probably subside at least that over a couple of years. Most important are the clinical improvements. So the NDI scores are significantly improved and maintained compared to anterior cervical fusion. And you really need to talk to your patients. Most of my anterior cervical fusion patients at their first post-op visit have that nagging posterior neck and interscapular pain and discomfort. I never knew what that was, but I think once I started doing arthroplasty, I realized that because we do an anterior cervical fusion, we jam the front of the disc space with a tall disc space spacer that kind of crams the facet joint posteriorly, and I think where that facet pain comes from. Therefore, taking that analogy with disc arthroplasty, the disc arthroplasty height is not as tall. We're not impacting the facets as much, and I think that's the main reason why there's substantially less posterior neck and interscapular pain in these post-op patients, especially early on, but that improvement is maintained in the NDIs over 10 years. Again, very substantial, durable results. Here's the neurological improvement based on the neural decompression. Again, superior to anterior cervical fusion and durable and maintained over 10 years. Mean neck pain score, like the NDA, again, substantial improvement in a trend, not statistically significant, but durable and maintained over 7 to 10 years. Arm pain, likewise. SF36, probably not as important for one-level anterior cervical operations, but here showing non-inferiority to anterior cervical fusion. Range of motion. If we're putting a motion preserving device, we want to make sure it's still motion preserving. And this is probably the highlight of the talk, which is the maintenance of the motion at the level, the index level over 10 years. Clearly, the cervical fusion patients lose their motion. They get a pseudoarthrosis or a solid arthrodesis, and they have little, if any, motion. And this is the reason why we do arthroplasty. Revision rates in the FDA study, the numbers are kind of squirrely. If a surgeon added a cervical collar post-op, that was considered a failure or a revision. So you have to treat these numbers and the definitions very carefully. But at the end of the day, revising, meaning going in and changing the disc arthroplasty or to a fusion, or taking the arthroplasty out device and putting something else in, or reoperation exceedingly low on the order of 1% compared to the fusions, which was 3%. Heterotopic ossification, Jens briefly mentioned we need to be concerned about that. You know, in an anterior cervical fusion, if they get HO, it's okay because the segment is fused. But in disc arthroplasty, the HO can lose the motion of the device, and so we end up having a null result. Or if you get significant HO, you could get recurrent stenosis with bridging bone in the canal, or even particularly in the foramen. What we're really worried about is the grade 3 and grade 4 HO levels, and you can see out to 24 months and all the way to 10 years that the rate of HO is about 20%, which is certainly acceptable. But I think most of our patients functionally, as Jens has showed so many wonderful pictures of 15 and 18-year follow-up, are still doing quite well with maintained motion. So again, just to review, the overall one-level findings are summarized here. Improvement, superior to ACDF, minimal revisions, minimal subsidence, and maintained motion with a low HO rate. Well, most importantly, as we all started doing arthroplasty, we wanted the 2-level data so that the insurance plans would cover these because we know that, again, it's commonly a multi-level condition, not a single level. This, as I had mentioned before, five categories of improvement for the primary clinical outcome for the FDA to conclude that this was a safe and effective device with overall success. They took the same criteria and just duplicated for the two-level clinical study. Again, about 250 to 300 patients in both arms, identical statistical methods, identical primary and secondary objectives. The recruitment for this study was extremely high, as it is for most devices. I would challenge any surgeon who says they follow their patients for 10 years. Probably most don't follow them more than a couple months, if not a year. But this study, you can see the recruitment rate for 10-year follow-up was in the order of 85%, which is extremely good and helps us understand the long-term successes. And as most of you know, the arthroplasty studies by every company, virtually every company, are leading the industry on the statistical soundness of the studies. Again, these are the primary outcome measures. They dropped the FSU, which was probably a good one, but otherwise the primary and secondary outcomes are similar. Here's the overall success. Again, very impactful graph, sustained over 10 years. Superior success of arthroplasty over anterior cervical fusion, not just non-inferior, sustained and durable result. NDI as well, statistically superior, not just non-inferior, durable out to 10 years. Mean NDI scores, again, reflective of that improvement in neck pain because we're maintaining the motion rather than providing a stiff joint. Neurological success, which is probably more a direct effect of the decompression that it is the implant. Neck pain scores, again, showed in a different graphic format, sustained and durable over 10 years. Arm pain, again, more reflective of the decompression than the device. Mean SF36, again, I'm not sure that that was very relevant, even though we start to have PROMs and functional measures as part of our research studies. And then range of motion. So out to 10 years, the two levels, each level has maintained the motion. Again, proving that we do have motion that's sustained over 10 years in properly performed cases. The level of subsidence and HO, again, a little bit higher when you get to two levels, but again, overall quite low at 13% or 39% if you add two levels. Adverse events, two-level LP versus two-level anterior cervical fusion. You can see a 1/3 rate of secondary surgery at either index level and at adjacent level. And probably the most important two statistics are the bottom two. So a half or 50% reduction in adjacent level disease over 10 years. Now, there are certainly a lot of preeminent master surgeons who do a lot of two-level ACDFs and will say, I don't have adjacent level disease. I don't operate on them because it is so low. I would actually challenge those surgeons. How good is your follow-up on two-level ACDFs out to 10 years? Well, this statistically, with an 85% compliance rate in recruitment at 10 years, a 50% reduction in anterior cervical adjacent level disease is substantial and significant. This is the only stat that I have to tell patients about not having to have secondary surgery, and they're always in favor of having arthroplasty over a fusion. And here it's just shown graphically in a different way, the index surgery and the time to require a secondary surgery at an adjacent level, and you can see it goes way out beyond 10 years with a substantial and durable result. So I just want to finish with just reviewing the indications and contraindications, which I think Jens and Rod would agree have changed over time. These were the indications. So skeletal mature, failed 6 weeks of non-operative therapy, herniated disc, spondylosis, or stenosis. Arguably, this indication of visible loss of disc space height compared to adjacent levels, that probably has changed. So we are now operating on people with disc space height reduction as part of the degenerative process. You still don't want to put these in infected osteoporotic patients. You still do not want to put this in cervical instability. This category here is the harder one to judge. You know, how much is severe bridging osteophytes, loss of disc space height, loss of motion, facet arthropathy. I've been very successful at using this bottom one, which is absence of motion. If there is no motion at all, translation, especially or anterior posterior opening of the disc space height, I do not replace the motion into a spondylotic fused segment. But even at an advanced stage with facet arthropathy, if there is some preserved motion of that disc space, I've certainly had good results by putting in an arthroplasty. Basic concepts for spine surgery. Don't do this operation for primarily axial neck pain. Do it in skeletally mature patients. They caution you over the age of 78, but I don't think there's any data to support that. There is a little bit of an interest in taking pseudoarthrosis patients or fused patients who have persistent neck pain and revising them into an arthroplasty. I don't have that experience. I don't think I'll have that experience. I think that's probably a little bit of a stretch on the indications. I'd be interested in Jens's opinion on that. Currently, it's not FDA approved for more than 2 levels, but I'm not sure that there's any reason why we can't do it more than 2 levels contiguous, especially in the appropriate indications. It's just sometimes an issue of its insurance reimbursement. Here are some of the FDA required things I have to talk about the risks, which you see there. Real quick, these are simple, straightforward cases, even more simple and straightforward than ones the fellows presented. A 42-year-old with right arm pain, numbness, and weakness, sort of a clear C6 radiculopathy with a little bit of myelopathy on exam. Has a big disc osteophyte complex at 5-6 and C6-7. Right-sided at C5-6 and left-sided at C6-7. The radiculopathy is on the right side. Hard to tell, but that's pretty significant stenosis at C6-7 on the left. Here you can see motion is preserved at both of those levels. So you see inflection, the anterior disc space collapses, the interspinous process distance opens up, posterior disc space opens up, and the reverse and extension. So there's mobile segments at the affected level. I decided to treat this as a 2-level C5, 4, 5, and 5-6, or 5-6 and C6-7. And here they are at immediately post-op. The second case is a 53-year-old with 16-month history of left-sided arm symptoms, radicular in nature, does have some myelopathy findings, so a combination cervical radicular myelopathy. Again, 2-level sort of right-sided disease at C5-6, central disease at C6-7, and again, a 2-level disc arthroplasty, postoperative x-rays, again, preserved motion. You can see an extension. The disc device collapses in the back, opens up in the front, and inflection closes in the front, opens in the back, and there's a little bit of translation that's preserved. So again, the technique, which we're not going to go over, is basically the 4 steps described here graphically or visually after an appropriate wide bilateral foraminal decompression. So even if they're only symptomatic on the left, you need to do a wide decompression on the right so that they don't develop a postoperative contralateral radiculopathy. Simple steps: trial, drilling, rail cutting, and then implanting the device. Like the FDA studies, I do 2 weeks of NSAIDs. I used to instruct patients to just use over-the-counter, and I realized that patients were not compliant with that because they would take it as needed, which is what they normally use over-the-counter NSAIDs. So now I literally write a prescription for 2 weeks of once-a-day NSAID to make sure they understand that it's important to take the NSAID and get better compliance. I don't put people in braces. I put people right back to work, including heavy labor. I let them go right back to cycling, golf, tennis. I'd be curious to Jens's and Rod's experience on returning to skiing and some of those other high impact or potentially high impact activities. This is one of the techniques I'm very proud to sort of be at the right time in the right of my career to have this develop and be able to master the technique and the indications for that surgery. Fantastic. Thank you, Rick.
2 quick questions from me. As always, I have questions I need to understand. I'm a slow learner. So when we have multi-level disease patients, we had 2 cases which elucidated some understandable controversy, one by myself, one by Dr. Oskuyan. Do we treat just the target level that we strongly assume, or with the power of disc arthroplasty, should we strive to kind of have a more global solution? So focused disease management, targeting one level, trusting the motion preservation to not aggravate the adjacent degenerated level, or go for a bigger, more comprehensive solution? Thank you.
Yeah, it's always the greatest question of all time, right? Which basically is, do we treat the level that we think is symptomatic and has radiographic support, or do we add on or treat the level that may be more radiographic than actual clinically relevant? Again, I'm kind of a minimalist and old school neurosurgeon. I also am the son of a retired interventional radiologist. And I think the old adage is you can always come back and do more is important to keep in the back of your mind. And remember that if our complication rate for a single level anterior approach is, let's say, realistically up to 5%, all comers, you've just added 5% complication rate to a level that may not have needed surgery. And if you believe in disc arthroplasty and trust the biomechanics and you trust the 10-year data, which we've showed, you can be really reassured that the adjacent level should not go on to advanced degeneration, at least within 10 to 12 years. And I think you have that open conversation with the patient. Every patient comes to us and says, I only want one operation and I will never want to come back. That's not realistic. Everything we do in the spine, as simple as a herniated disc, has a potential risk of recurrence, adjacent level disease, or postoperative, misadventures. So I think you have to have that open conversation with the patient. But I am typically lean more towards doing less, fewer levels, and doing what I can sort out as to be the symptomatic level.
Very erudite answer. One of the, I just want to editorialize to that, maybe ask you for your opinion about that. One of the big questions in terms of the differences of one versus multi-level disc arthroplasties, which showed a clear favoritism of multi-levels, was the fact that we as surgeons, and I myself was guilty of that, compromised more, putting in just single-level devices in a nest of more degenerated adjacent segment diseases, trusting the disc, thus adversely influencing the long-term outcomes adversely. So the multi-level has given us a power to be more comprehensive. So just your thoughts, is that a protectionist statement, or is that a sensible, possible academic explanation for why single levels did not do as much better as fusions compared to multi-levels?
Yeah, as always, an amazing question and insight. I think you're absolutely correct. The data shows us that 2 levels perform better than 1 levels. So I think you have to balance what I spoke about, the point of what's clinically symptomatic, what you can trust won't go bad over 10 to 12 years, versus, maybe you just add 30 minutes or 45 minutes to the operation to do the second level. Most of these are still done as an outpatient. So I think, again, it's an open conversation that you have with every patient. And we're always biased by our last, 1 or 2 bad results, or our last 1 or 2 really good results where we might have gotten away with it. And I think for the surgeons with the early experiences, develop sort of a strategy and stick with it for a while. If you change your strategy too often, you're really not going to know your own personal experience. And so I would say sort of balance those 2 conversations we just had with these 2 questions. And there's not a wrong answer, to be honest with you. I think of the cases that were shown today, the only one that I would have trouble with was that non-contiguous segment at C3-4 and then the treated level at C6-7. Now the patient results are what they are, and he's had a great result. But the adjacent level disease, I think you've made an excellent point, could argue very, very strongly that should go ahead and do the 2 levels.
Hey, Rick, that was a terrific talk. I know we've gone over a little bit, but I don't know if you knew this, but Vince Bryan practiced here in this hospital.
Oh, really? Wow.
Yeah. And Jens and I know him. He's a great guy. He's so smart. I mean, he's like a savant. I mean, he thinks totally different level. I spent a lot of time with him.
Oh, very cool. I did not know that.
Yep. And, he's a retired neurosurgeon, but he did a lot of stuff on the side. And artificial discs, I remember everyone told him, said, Vince, you're crazy. This will never work. I think he ended up selling that thing for like $300 million. So I was just going to go back to some of the things we talked about earlier, and I appreciate your discussions about, the indications and long-term follow-up. Why is it, this drives me crazy, why is it in the United States that cervical arthroplasty has not taken off like it has in Europe? I mean, I still see patients in my clinic that have gone to Italy and had 2-3 levels done by Rudy and some of these other guys in Germany. And what's your take on, because I feel like industry, insurance companies, hospitals, it's like this big, huge, mix of different things that go on. And then you look at arthroplasty, it's cost effective, it's cheap, it's long-term data is good. And for some reason, like I told you earlier, I get denied all the time.
Yeah,
by insurance companies.
Yeah, I only have one simple answer, and it's not very scientific, but I think it's true. And that is when it first came out in mid 2000s, 2007, 2008, insurance companies were totally against it. It was experimental, it was investigative, and they have a right to make that decision because they're paying for it, right? I mean, that's the hospital system that we live in the United States. And I think there was so much pushback that surgeons said, well, I'm not going to waste my time doing peer reviews, doing medical director phone calls, writing letters, sending in the literature to support the treatment. I just don't have time to do that. And so surgeons moved away from it because the alternative operation in ACDF is an amazing operation that's been around for a long time with great results. And we should be almost able to do those cases blindfolded. And so I think it drove surgeons away from doing it. And then slowly over time, the insurance companies and the payers have come around. And while it's still a challenge in different parts of the country, we're finding it much more easier to get approvals. We even get some hybrids approved, which is kind of amazing. And so, but I think that's simple. That's the simple question. And surgeons are reluctant to then fight the fight for our patients.
It's too bad because I think it's a great operation.
Absolutely.
So much more to talk about. We need to hopefully have you here more often. Love our collaborations with you, love learning from you, and you're a icon certainly in the Southwestern region and beyond. Thank you, Dr. Chua, for being here today. Always just a lot of fun and very insightful to talk to you. Appreciate
Always
it.
a pleasure. Thanks so much for having me. And
Great to see you, Rick.
good luck. Good luck to all the new fellows. Bye-bye.
Thank you so much. Bye-bye.
Great job, you guys. Way to put it together.